Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. We're picking up with Dr. Tim Gilligan, GU oncologist and expert in physician-patient communication, here in this episode. Let's turn more to physician and patient communication. How did that become a major interest in your career that led you to do additional training on this?
So there's actually a long history to that, I think. You had asked at the beginning of the interview sort of a little bit about my background, and some pieces that may be relevant, I think, around this work, honestly, are the fact that before I went to college, when I was in high school, I studied classical piano very seriously. And then I was an English major in college. And so I came into medicine with a strong interest in the humanities and kind of the human story. So I loved about novel and poetry. And in medical school, my mentor was the head of bioethics at my medical school, as well as the head of pulmonary and critical care medicine. And we ended up doing a bunch of work on talking to patients about end-of-life decision-making and how you withdraw aggressive life support, take someone who's on a vent, needs to be extubated, and things like that. So early in my career, that became kind of a focus of my work, just this humanity of death and dying in particular. And then when I got to residency, I got onto the ethics committee because I was interested in that stuff and ended up serving on ethics committees all the way through my career. I finally got off of that just a couple of years ago here in Cleveland Clinic, but I did that at Brigham and Women's and Dana-Farber and the Cleveland Clinic. I just was interested in the human story of being ill. And in some ways, it links back to me with sort of the stories I heard growing up in Nebraska. I didn't grow up in Nebraska, but going out to Nebraska and seeing my grandfather and hearing those stories about, it wasn't about the exciting biology of disease and genomics. It was about taking care of people who were ill and what it meant to be a doctor, and presence at the bedside and presence in the home and doing your best by sick people. I think that was kind of the vision of medicine I came in with, that I wasn't guaranteed the opportunity to cure people, but I was going to be taking care of people when they were sick and suffering and doing everything I could to help them. And then when I took over the fellowship training program at Cleveland Clinic for HEMONC, I did that for about 10 years. What struck me was that the fellows knew a lot of biology and a lot of medicine. But when I listened to them talk to patients, I felt like they were not trying to imagine what would it be like to be that patient. Like, how does it feel if a doctor tells you you have cancer? How would it feel if a doctor told you your cancer had spread to your liver or was no longer curable, or the chemotherapy wasn't working, or even just that you had a curable cancer, but you're going to have to go through 4 months of unpleasant chemotherapy and you weren't going to be able to work? And it really challenged me to think, how could I teach them to do better? So then I went out and got training. I spent time with the OncoTalk group that Tony Back and Walter Bale and Bob Arnold and James Tulsky developed, where they teach faculty how to teach communication skills to oncology fellows, and then did a lot more training with the Academy on Communication and Healthcare. But for me, it's been a really interesting journey because it's made me realize that communication skills, we're told when we grow up, in a sense, you have it or you don't. You either have good personal skills or you don't, or you figure it out on your own or you don't, or you watch someone communicate well and then you figure out what they did and you just do it, the sort of see one, do one, teach one kind of idea. And I realized that communication skills was actually a much more specific, definable, teachable set of skills and stuff that people could get better at, but that it was a lot more like a motor skill, like learning to play piano or learning to play tennis, that people needed to have a clear understanding of what the skill was. They needed to know what it looked like, and then they needed to have an opportunity to practice it to get better. And one of the things that's been most rewarding for me about it is my own experience with patients. I really feel like has improved a lot as I've gotten better at it, as I've I think, become a little bit more sophisticated in my imagination of what it's like to be a cancer patient and what cancer patients need from clinicians at a human level. And then the other piece of it is that the most rewarding thing, I think, in medicine is the relationships with patients. And so if we become better at developing relationships and develop stronger and more trusting relationships, our own day gets better. We have better conversations. We have closer relations with our patients. The meaning of the work deepens. And so I think there are a lot of benefits to go around. As you can tell, 'cause I'm going on and on about it, I'm pretty passionate about the whole thing. In some ways, I had a lucky foundation in music and literature and then in training, and then an opportunity to practice teaching fellows when I ran the fellowship program is where it all kind of came together. And then out of that, the Cleveland Clinic decided it wanted to train all their doctors to communicate better. And a few people, Adrienne Boise and I, were already doing that. She was doing it in neurology. I was doing it in hemonc. So they asked us and a couple of other people who are deeply embedded, Amy Windover is a psychologist here who's done work in that area for a long time, to develop a program for training. And now it's mandatory at the clinic. All the physicians here are mandated to get 8 hours of communication skills training if they work here. And the fellows and residents go through it too. And so that's been an interesting journey. I think we've trained like 8,000 clinicians at this point. So it started as a little thing and it became this huge project. And now it's half of my job title, really.
Have those efforts been well received, or are a lot of people saying, 8 hours I don't have, and is this really helpful?
So it's interesting. So when we first started it, our biggest fear was that if you tell doctors you're going to teach them how to communicate, they run for the hills. That very few physicians sign up voluntarily for communication skills training. And so when we built the program, we tried very, very, very hard to develop a program that would feel relevant to them and useful to them and respectful to them. We felt like we couldn't walk into a room and tell a clinician who'd been practicing for 10 years that we knew better than they did how to talk to their patients. I mean, that would be arrogant and presumptuous. So we used a lot of what has been learned in adult education research about how do you effectively engage adult learners and how do you teach them in a way that's helpful to them. And so we tried to be very learner-centered. We would ask them, where are you getting stuck? What are the patient conversations you find hard? What are the kinds of patients you don't look forward to seeing again? Or what are the kinds of patients you go home and you think, gosh, I wish I'd done that differently, or that conversation didn't go well. I wonder what I could have done better. And what's interesting is that when you have that conversation and people see that everybody has an answer to that question, we all have bad days, we all have bad conversations, it becomes a much safer space to kind of engage in, well, what could we do differently? What actually would help us? And so our experience was that people would show up and they would be skeptical at the beginning of the day. It was all done in one day. So you show up at 8 in the morning and you're done by 4:30 in the afternoon. And by the end of the day, almost everyone who came was grateful that they had come. Although I have to say, a lot of the times what they were grateful for wasn't so much that we had been such fantastic teachers that they learned such great stuff. A lot of the time what they were grateful for was just a chance to connect with colleagues and to realize that they weren't alone having these struggles, that the fact that they had bad days didn't differentiate them from everybody else because everybody has bad days and that everybody struggles with this stuff. And it kind of normalized it at a certain level. And they learned from their colleagues. We actually worked in a very facilitative way. We assumed we have 10 doctors in the room. They know a lot. They have a lot of practice communicating. If we can just get them to share what they know with each other, a lot of learning will take place. So it wasn't like we're the experts, we're going to teach you. We tried to create an environment in which we could all learn from each other. And I think that was more respectful, it was more beneficial, and it allowed people to really engage. And then the last thing I would say is that when you put people into role plays and you have them practice having hard conversations, they start to realize, oh, that really is hard, and we're not as good at it as we think we are. And if I were a patient, I wouldn't be entirely satisfied with the current skill set that I'm seeing here today. And so it would kind of validate for them why we do these courses. It's sort of like someone saying, I know how to play tennis, and then you put them on a tennis court and you hit them a ball and they can't hit the ball as well as they thought they could. They realize, oh, I guess my backhand needs some work after all.
Well, that's really one of the big questions I had, is that this is interactive teaching. It's intensive. You, in the OncoTalk program, it's, I think, a teach the teacher kind of approach. But what about the docs who don't have this available, which is most? Are there online videos or other self-teaching tools? Or, is it going to be like tennis or golf where you can't just read about it or watch it and expect to be doing it optimally?
Yeah, no, I think that's a really good point. I don't know how to do it cheaply well, because there is that issue of you need feedback, you need practice, because you need the muscle memory. Mm-hmm. You need to feel the words coming out of your mouth. So if you're going to practice making empathic statements, you need to practice saying the words and get comfortable with phrasings that feel natural to you. And you need feedback from people who can tell you what's working well and what could be done more effectively. And it's hard to do that on your own. It really is. It's hard to observe yourself. It's much easier to be observed by somebody else. And when you watch someone else practicing, you can learn because you can see, oh, they're doing something I do and I don't actually like it now that I see it, or I really do like it, so I want to make sure I keep doing it. So I don't know a cheap and easy way. There's a lot of research going on now for online training. But I think it's like, the analogy I use is if someone comes to me and says, you know what, I really want to learn how to ski moguls, but I only have an hour over lunch. Could you give me a noon lecture on how to ski? You can't do that. That's not how you learn hard skills, right? You have to actually practice doing it in a real world environment. So I think my position is that we need to persuade hospitals and medical educators that this needs to be taught. Now, the good news is that medical schools are starting to do this. And that's really where the time and resources exist to do it well for everybody. It doesn't help the people who've already been trained. So that's at least one, I think, bright spot is that fellowship residency medical school is doing a lot more of this work now.
And all the people who are climbing up through this will have their chance to funnel through that before going on. Yeah.
Right. And in terms of those of us who are already trained, that hopefully hospitals will more and more prioritize this. I have to say, there is a lot of uptake around the country. I know the Academy on Communication and Healthcare is busy running around to hospitals doing training all over the U.S. The Cleveland Clinic does a little bit of that. I've been to a few centers to do training outside of Ohio. And the interest only seems to be growing. Now that at least there's some money on the table around patient experience, you can make a little bit of a business case for it, which is helpful. It's easier to get hospitals to buy into it when you make a business case for it. But what I would like to see it is as a clearly defined professional competency. So if to maintain your medical license, you have to get 100 hours every 2 years of CME, I would like to see 10 hours of that mandated around interpersonal communication skills, because it's a lot more than 10% of our work. And so much of CME is focused on cognitive stuff and knowledge. And it's great to know a lot, but we also need to know how to work with a team of people and interact better with our patients. But I have to say, I'm optimistic because I see more and more hospitals willing to invest in it.
How does the presence of the computer and the EMR in the exam room and the compulsion to document along the way change the dynamic and the whole process of trying to convey and communicate effectively and empathetically?
I think the computer is a huge problem, but it's not going away, unfortunately. The analogy I draw is if I go home and I'm trying to talk to my wife or one of my kids and they're watching TV, it doesn't feel the same as if I have eye contact with them and they're really engaged with me. And watching the computer screen instead of eye contact with the patient, it makes it hard to feel fully engaged. The challenge is that we do need to document. And it's unfortunately it's linked to billing and compliance and all this stuff. I hear rumors that those links are going to be loosened, which could be good. At least loosen the documentation requirements would be a plus for us. I know a lot of different doctors work in different ways. Some people feel like they need to chart in the room. Some people feel like they don't. There are a couple of pointers that can help. So one is to remind the patient of why getting everything accurately in the computer is to their own benefit, right? If their situation is accurately documented so that everyone else who's taking care of them can see it, that helps them get better care. We can use the computer to show them CT scan results or x-rays or blood results. During emotional parts of the interview or more serious parts, getting away from the computer and making eye contact is particularly important. So just being cognizant about that. But I think it's a tricky subject. And unfortunately, I think it does hurt our relationship with patients. And we see, there are famous examples of how that plays out. There's the child who drew a picture of the pediatrician's office, with the pediatrician with their back to the patient typing on the computer screen that I think JAMA put on their cover years ago. And there's a funny story. I don't know if one of the newspapers was writing about it, where a doctor related to how they were seeing a patient and the patient asked them if they were married and they said, no, they're not married. And the patient's child said, of course you're not married. You're married to the computer.
Yeah.
So this is what our patients are seeing.
Yeah. And I believe there have been studies that speak to lower patient satisfaction when docs are engaged heavily in the computer when they're in the exam room. So it's a real challenge that we have, serving a couple of masters. Everyone, I think, wants to communicate effectively, but as you note, there's a lot of demands around what needs to be documented, and some people do it different ways. Yeah.
Well, I think the biggest loss in some ways I see in the hospital setting, because my recollection of being a resident is, yes, we had to document, but we were handwriting notes back then. And it took a certain amount of time, but daily progress notes were reasonably quick. And so I had time to go back and sit with the patient and really get to know them. And what I see now with residents that really worries me is they spend all this time with the EMR, reading notes, looking at studies, going over lab results, and then spending all this time documenting. And they don't know the patients the same way. They don't know their social history and their background, and they don't just sit and talk to them. And that was, as I, earlier in this interview, I was saying, that's what drew me into oncology, was sitting in the room talking to cancer patients. I was just so engaged getting to know them and trying to figure out how to help them. And it's much less engaging to sit staring at a computer screen, looking at all the stuff we have to look at and writing this really long documentation that we have to do now.
There's been an argument that the concept of shared decision-making is all good and well, but in reality, it's not attainable when we only have a handful of minutes actually to interact with the patients. And, I think that is a real issue, whether it's in the academic or community setting, large or small healthcare systems. There are plenty of, I think the majority of oncologists have some real time pressure and RVU generation productivity issues that I think make it harder, if not undermine the efforts, all the best laid plans for good communication. And so, there's a workout for 7-minute abs, but, is there a way to do artful patient communication if you have only a 7-minute encounter in actual time with the patient?
Yeah, I guess my short answer is no.
Well, that's fair. I mean, I'm just saying that, does something have to give here? Because, is the system fundamentally flawed when docs are needing to see 25 or more patients a day? Is that just undermining the ability to do empathetic, good communication?
Yeah, I think I have a couple of thoughts about it. So yes, it's a challenge if you're trying to see 6 patients an hour in oncology, you're not going to be having very deep conversations with those patients. I think the more we can be smart about distinguishing which patients need 15 minutes and which patients need a half an hour or whatever the number of minutes is helpful. One thing I feel very strongly about in terms of communication is that being a good communicator means being able to communicate more in the same period of time. It's similar to, being a good chef in a restaurant. Like one of the reasons, I love cooking at home, but one of the reasons I could never cook in a restaurant is the number of plates of food you have to serve an hour at a restaurant is so much greater than what you have to serve in your own house. And it's they're much better at it than I am. They're professional chefs and I'm not. And similarly, if I'm a really good communicator, then what I can get done in 15 minutes is going to be more than what someone who's less good at communicating can get done in 15 minutes. So the ask with communication skills is not to spend more time with patients, but to use that time more wisely. And so one very practical piece of that is we spend too much time talking to patients. They don't retain most of what we tell them. So a lot of the time we spend telling them things we are wasting because they can't retain it. Spending more time listening to the patient and getting to know them is often more valuable to the patient, but it's not the habit that we're in as clinicians. So there are a number of trade-offs and choices that need to be made. But I do think if you're going to have a big conversation with someone, you're going to tell them a cancer diagnosis, you're going to tell them they're progressing, you're going to make a big treatment decision. And to do that in 7 minutes, I don't even know how to start that conversation.
Right.
But if I do know the patient, if I have a sense of them, those conversations are much easier than if all I know is their scans and their blood test results. One analogy I was thinking of recently that was surprising to me was when Heather, my wife, got pregnant with our first child, our daughter. I wanted to take pictures of our daughter growing up. So I went to this adult ed class on portrait photography at Brookline High School because we were living in Boston at the time. And I thought they were going to teach me about how to use a camera and how to set the f-stop and the shutter speed and which film to choose. And instead, the portrait photographer taught all about how to create a moment with a human being that was worth taking a picture of. And I feel like in some ways in medicine, I've now learned the same thing, which is I was so focused on understanding the biology and the pathophysiology and how to choose the right drug. And now this communication work is really about how do you create a relationship in which you can make good decisions and you can get the best outcome for the patient. And that there is an important humanistic element. You still need to know how to use the camera. You do need to set the right shutter speed. You do need to choose, back in the day we had film with appropriate film, but you also needed to understand that there was a relationship between you and the subject and that required a different skill set.
You were the lead author and I think the lead on the committee working on ASCO guidelines for patient communication. There are a lot of important things covered in that, but one of the big ones is talking about goals of care and end-of-life care, which I think is one of the more egregious shortcomings of contemporary medical oncology. Not everywhere and with everybody, but I think we do relatively poorly with that. And can you offer any kind of suggestions about what would be the highest impact lessons and things to do differently and better that could improve how we do with talking constructively about goals of care and realistically about prognosis and end-of-life care that would fundamentally change some of our shortcomings now?
Yeah, I think there are some things that can really help. Actually, the person who I found most helpful in that particular realm is Tony Back in his work with VitalTalk. They actually have a paper out about a process they call REMAP, I think REMAP, where they actually walk through some specific steps for how do you have the goals of care conversation. And I feel like it's at that level that people need help of how do you broach that subject? Like, I'm wondering if this would be a good time to kind of take a step back and look at the big picture, or would this be a good time to talk about what this means? Because the way this actually plays out is like, you're seeing a patient, they come in, they have a scan, and now they have 4 large liver metastases, or maybe even something less dramatic than that or whatever. But their prognosis is clearly taking a turn for the worse. And so you tell them that, well, your scan shows some liver mets. And so they say, oh, so what do we do next? They say, oh, well, so we're going to move on to like 3rd-line chemotherapy or whatever, right? The patient has completely missed the significance of this, potentially. Not all patients. Some patients really get it. But you haven't actually told them what the significance is of it. And so creating language and patterns in conversations where you stop and you say, I've just told you that you now have 4 tumors in your liver. Would this be a good time to talk about what that means? Because the patient is scared. They don't want to hear, this means your life is going to be shorter, that death is more imminent now than it was. But they're certainly thinking of it. And I worry that as oncologists, we think, oh my God, if I bring up death, it's going to terrify the patient. I can guarantee you the patient's already thinking about death if they have cancer. It's the first thing people think of when they hear of cancer. But we don't talk about it. And then we have this sort of partnered collusion because I don't want to talk about it because it's uncomfortable for me. And the patient doesn't want to talk about it because it's scary. So we have to be the grown-ups and put on our adult pants and be brave enough to open the door. And what I like about Tony Back's work is he really gives very specific language. And it's not just him. He works with the team. He's just the senior author. But gives specific language and practices to develop for how do you bring this stuff up and how do you bring it up earlier. And I've been struck with my patients about what a difference it can make. I wrote an essay for JCO about one person I took care of who he had lived much longer than I ever thought he would, honestly. He had small cell carcinoma of the prostate. We got to a point where chemotherapy was not going to help anymore. It had helped much more and for much longer than I thought it would. But we got to the point that it was not going to. And I come into the room and I was just really sad because I'd gotten to know this guy over 5 years, which is a long time to live with metastatic small cell carcinoma, and heard all about the life adventures he had in that period of time. And this was time to talk about hospice. And he could see my disappointment. And he said, Tim, you told me this was going to happen. I was expecting it. You bought me 5 years. And it was such a gift to me that I had laid that foundation early on and he had heard it and understood it so that when the time came to have that conversation that it was time for hospice, it wasn't a shock to him and it wasn't totally out of the blue, but he was in some ways prepared for it. And it just motivated me to try to do that more consistently, to be really clear up front that this is what this means. And these are the options we have for treatment. And these are the best case scenario and the worst case scenario and the most likely scenario. But to be brave enough to sort of say that earlier on in the conversation and then to feel skilled enough that I have the words to say this in a way that feels tactful and caring and sensitive and yet also honest and truthful. Because I think we get stuck in this dilemma of we tell the truth and we destroy all their hope, or we sustain their hope by not acknowledging the truth. The skillful oncologist can do both. Phil Kantoff said that to me early in my training. He said, what you need to be able to do as an oncologist is to tell the patient the truth and to have them feel better about their situation as a result of the way you had the conversation.
That's great. I mean, I really agree with the issue of the collusion, and that, I think a real part of the problem is that it's hard to have these conversations. And I think especially in the hospital setting, maybe in an ICU where things are going very poorly, you'll try to go over all of the challenges and then say that, okay, well, this lab is better, but these 4 are worse. And they'll say, oh, but you said the LFTs are getting better. So great. And then you end up walking out of the room with this, well, okay, maybe next time. But these are hard conversations, but I think we do owe it to the patients to not gloss over the big picture. So
part of, I think, what makes it hard for us is that we really care about our patients and we want them to do well. And we feel this huge responsibility for what happens to them. And one thing that I talk a lot about with the fellows still is the importance of keeping track of who owns what. And what I mean by that is that we don't control what happens with their cancer. And it's not our fault that they have cancer. And there's a limit to how much we can impact what's going to happen. And that if we try to reach in and sort of take care of everything and take responsibility for everything, it's overwhelming. And then we don't do the stuff that we actually need to do. So I think that's another piece of the end of life stuff, is just keeping track of it's their cancer and it's their life. And we didn't bring this to them. We're there to help them, to make it better, to do everything we can on their behalf. But if we take ownership over it, it's not really fair to ourselves. And I think we have a kind of impossible task at that point. And so I do feel like the issue of boundaries is really important for navigating the end of life stuff in order to make it manageable. I hope I said that in a way that makes sense.
I think you did. Well, Tim, thanks so much for taking the time. These were sometimes difficult things to talk about, but I really appreciate your contributions both in GU oncology and, of course, and really leading the charge on such an important issue as physician-patient communication in oncology ahead of everything else. I think it's the cornerstone of what we should be doing. So thank you really for joining me. It's been great.
Thank you. It's been great talking to you. I appreciate the opportunity.
Thanks for listening. The West Wind podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.